So good morning, everyone. Thank you for joining us for our RHC webinar. Today we have Kate Hill from the compliance team joining us, and she is going to talk about RHC Compliance 101. I know she has several slides prepared, but this is a really great opportunity just to ask some of your questions that you run into in your clinic setting. And then I have compiled a short list of questions that I've been receiving that I've been passing on to Kate that I think would be beneficial for the group. So with that said, as always, these are as informal as possible. So if you have questions, please, you have the control of your mic, so you can unmute yourself and blurt them out. Or if you want to put them in the chat, I'll be watching the chat for Kate. With that said, Kate, I'll turn it over to you.
That's great. And so since we don't have 1,000 people here, so please stop me, raise your hand, get to Laura to tell me to ask a question right at the time it hits you, or if there's a picture that. So we're going to go through a number of things today, some hot topics, compliance, and of course the mandate, which I'll save that to the end because I just got word from an attorney on that one, but we'll have to see what CMS says. So first thing you need to know is the public health emergency is extended at least to January 14th. Now, the secretary did say that they would give clinics, entities 60 days notice if it was going to end on January 14th. We have not got that notice. And as best I can tell, we're well within 60 days of January 14th, probably closer to 6 weeks, right? So we haven't heard. So that makes me think it's going to May. And so that's probably no surprise to any of you, but that allows you to, have your other locations, not have your NP there 50% of the time. Those kinds of things are all still allowed, but just know the day it does end, and that's why you need notice, it ends and you can't do those things any longer. So just bear that in mind. Right now we're rolling till January and probably till May. So if you don't remember the Appendix Z update, there were a couple things there for emergency preparedness that was effective back in April. You must include emerging infectious diseases as one of your HVAs. So everybody has that. Obviously, we've lived it for almost 2 years. So now you're going to have it as one of your risks for your clinic. You have the response to it already done. You've lived it. Just write it, get it in your plan. EID as a risk, and then what you plan to do about it, because like I say, you've done it. And so it's all about, obviously, widespread pandemic for sure. And you always want to be in sync with your state law. That goes without saying. I don't need to say that. Now, the testing, the one thing that changed in the testing in this update is that you can't have a test that's an exercise on something that's not in your list. So if you're in Oklahoma and you are not in hurricane place, like I am, in Pennsylvania, we get the dribbles of them, but you don't get hurricanes, I don't believe. And so, but you could do a hurricane tabletop. That's not going to count. And so I don't know if your surveyors are going to see that, but that is in the new guidance that you must test what you've got as a risk, which, makes sense. You're going to be doing a tornado drill and some other things that are appropriate. Everybody should have a power outage in their risk assessment, those kinds of things. Now, an actual event, of course, doesn't count. If you didn't have pandemic in your risk assessment last year, you've obviously are able to write that up, and it counts 100%. As a matter of fact, we are accepting exercises 2 years in a row on the same thing. They are very different. So COVID last year was the beginning of it all. And how did we manage and getting masks and gloves and sanitizers and all those things, and social distancing and keeping patients out of the waiting room. All those things were the write-up for last year, for 2020. For 2021, you're writing up testing and vaccinations and all the rest of it. So it's a very different evaluation of the same pandemic because we're in a different place, and we will accept that hands down. And so just bear that in mind as well. Now, it did also add a little sentence about volunteers, which was very strange. We have not had a state that won't allow us to say in our emergency preparedness plan that your clinic does not utilize volunteers. End of story. Simply because we don't see volunteers in rural health clinics yet. I have yet to see one. And I know that a volunteer in an emergency is going to be whoever's able-bodied in your clinic at the moment to be able to help. But they did add this, that in their guidance, that surveyors are to ask the leadership to explain their staffing strategies Do they use volunteers? If no, do you have other ways to get emergency staffing? We find in rural health clinics that's not easily done. So I don't know how you want to address that one. A sentence or two, we don't use volunteers. And fact is, there's rarely any emergency staffing to be had. We have clinics that have had to close some days of the week and all those sorts of things. Can't close indefinitely, but definitely limited hours. So I would probably write it like that, but you should just know it's there. We're not looking for that real hard. I can promise you that for sure for our clinics. Now, and it also wants you to address how you manage waivers. You've lived that. Can you go to alternate sites, things like that in your plan? Now, these are the rules. I always tell you that Cornell University is the best site. You Google 42 CFR 491, pick 1.5, and it pops right up, and it's a nice little toggle switch. So if you want to see what does the law exactly say, this is where you go. It's much easier than the federal government website, much, much easier. So let's roll through these. And now if you have questions, pop them in so we can get them answered. Location must be in an area defined by the Census Bureau as non-urbanized and in a HPSA. Just so you know, your HPSA is good for 4 years, no matter what the date. So if it says your HPSA expires December 1st, it doesn't. It expires December 31st of the year, no matter when, even if it was back in January. And also, you are all rural health clinics, so you are grandfathered in. The big issue for you is you don't move unless you check the HPSA out in the next neighborhood. So, and you must have an NP or PA as a W-4, that's required. And they must work at least 50% of the hours of the clinic's operating hours, also very important. Now that's waived right now during the pandemic. So if you have to pull them or they're sick and they have to go to the hospital or to work or they're out, you don't have to cover the 50%. I would document that where they actually are in case a surveyor should ask you that. Also, the physician, NP, PA, midwife, social worker, psychologist is available to furnish patient care services at all times the clinic operates. So we don't have any patients in the back if there's no provider in the building, not one of that group. So we don't do blood checks, blood work. We don't do blood pressure checks or weights in the morning before people go to work. It's unfortunate, but it is required. So nobody gets in that back without a provider in the building. You must provide routine diagnostics and lab services. You must have arrangements with the hospital to take your patients. That does not have to be in writing. You just, if the surveyor asks, you can document this patient went in that hospital, so it's acceptable. You must have drugs and biologicals to treat emergencies. And you must have the ability to do all 6 of those tests and get the results right now today in your clinic, even when the clinic's in the hospital. Now, you heard me, you must have the ability. You do not have to do them. You just have to have the ability to do them. That means you have the machine, you have the controls, they're in date, et cetera, et cetera. So that will change once we ever get the government to pass the Modernization Act. That's one that's going to go away. And it's going to say, labs are readily available. How nice. You would have what you want to do in the clinic, that kind of thing. You'll do flu tests, you'll do pregnancy tests, you'll probably check for blood sugar, those kinds of things, but nobody just orders a hemoglobin or hematocrit. That's an old law from 1977. Your clinic must be primarily a rural health, cannot primarily be a mental health disease treatment facility. You can't even be 52% mental health. You can only be 49% mental health. That's another one we'd love to see changed, as we know that mental health is a part of everyday life in the clinic world. So you have to be 50% rural health clinic services, commonly called primary care. So one of the best ways to stay compliant with your group is to do mock surveys. Get the whole clinic staff involved. This is a group activity. One person can't keep a rural health clinic compliant. It's just too much. And so hold a kickoff conference with the staff, get them involved, print your checklist and hand them out to everybody, give people different jobs, and then do a walkthrough of the clinic with your checklist in hand. And I would add a red pen, which I should put there. Once you can answer yes to everything, then you're compliant, then you celebrate. Then you sit down with your policy book and you make sure you have all the policies you need and they hit the elements that are required. If you're provider-based, as most of us are these days, make sure that the policies for the hospital include your clinic, or they're clinic specific one way or another that you're named in there. Like this policy, infection prevention includes all entities of XYZ hospital, that kind of thing. So you clearly identified. And then in your binder, you refer to our clinic follows the HR policies of our hospital. Perfectly fine. It would be unusual if you didn't. So that's a good thing. Interview your staff to make sure they're knowledgeable about clinic policy. Let me say right there, the hardest thing for you and for us is when the clinic manager is out the day of the survey, when you haven't shared your knowledge. Please share it, because you do get days off, or you're sick or whatever, and it just happens to be the day we show up, and things do not go so well if you haven't shared where things are. What does that look like? Where, the kinds of things that they need to demonstrate to show up to pass survey. And then have a wrap-up conference with your staff and celebrate the accomplishments. Everybody's really worked hard to stay compliant, and now's their time to shine. I think you'll do really great if you do this. I would say once a quarter, if you can pull that off. If it goes to 4 months, no shame in that, but they need to understand this is an open book test. There's no surprises here. They can't survey you, we can't, and the state can't survey you to things that are not in the regulations. Some people will try. We work really hard at not doing that, but there has to be a rule that says we have to do this. So enthusiasm, not apprehension. And we hope your surveyor will conduct a fair and unbiased survey. We work, like I say, we train once a month, all our surveyors. Monday's the first one for December, to keep everybody on the same page. So this is our checklist. I'm happy to share that. Now you'll find with an accreditor, the checklist has extra things because we're required to a step above the state in our requirements. Now, the blue are things that are required for people that bill Medicare, but they don't typically do that in the rural health clinic surveys by the state. So you must have a corporate compliance plan. So if you see it in blue, it's a regulation, but not specific to clinics. It's specific to anybody that bills Medicare. And then if it's in black, of course, it comes right out of 491 and what that is. And if you'd like that, I can send that to Lara. So first thing, the name on the sign is consistent with what you have on your 855A. No matter how many years ago was that. Don't be changing the name without going into PICOS and updating it in there so it matches, because everybody uses that documentation. And then the hours are posted. You must have your hours posted on your clinic. And if they change, you can make adjustments to that. Now, I mentioned this already. Before you move, check with Lara, make sure that this area is still in a HIPSA. You can go to MI Rural, you can go to HRSA and check by location and make sure that you know, even if it's next door, because remember, you're grandfathered in if that neighborhood build up around you, but you're only grandfathered in at that location. You can't move unless it's in a HIPSA. Any name changes, report to CMS. And of course, your medical director is a reportable event. And that goes on a CMS 29 form to the state and to your accreditor if it's not the state. Sharps containers must be mounted and locked on the wall so they're not easily accessible. This one on the left would help, someone that has a need to get some needles would not hesitate to put their hand in there. So we don't want that kind of a container where there are patients. That's a lab container where no patients are there. We see that often in operating rooms. For red bag containers, if you have a red bag container, it is not required. You have to have it covered and a biohazard sticker. We recommend having a couple red bags so that if you get something bloody, dripping, drainage kind of thing, you can red bag them and put them in the place for appropriate pickup for biohazard. All your equipment is on a list, and the pieces that need biomedical checks have it. And so your EKG always does need to make sure it's reading accurately. The AED never. It's got a battery checker. The pads do expire, so you want to check those when you're doing your monthly rounds for all things that expire within the clinic. Now, in the clinic, all chemicals, all biohazards, all sharps, and all medications are secured somewhere in the clinic. So we're not leaving them out, that people can help themselves to these sorts of things or get into trouble with children and chemicals, et cetera. So just make sure they're locked in whatever room they're in. The OIG exclusion database is one of those examples of that may not see that with the state, but you cannot hire somebody on that list. So you should be running everybody that works in your clinic through that database once a year. It's very simple to do. You can do it 4 at once in about 15 seconds. and you go to that site there and type the names in, and it'll say, if no information is found, they're good. And that's exactly right. You put that in their HR file. So through the past 2 years of COVID, this has been the number one deficiency, and that is the people not knowing the difference. I know you're rolling your eyes, but we see it every day, not knowing the difference between a single dose vial and a multi-dose vial. And I'm going to suggest to you that you go back after this webinar and retrain your staff and make sure every person understands why a single dose vial should never be dated 28 days, that it's once and done. It shouldn't be in the closet if it's punctured. It's gone. And I know some people do that to save money. Fact is, there's no preservative in that vial, and it shouldn't be reused. It's a single dose vial for a reason. So once and done. Multi-dose vials, most people just date them on the 28-day open date. I would also recommend you have one of those fancy calendars that shows you the end of the 28 days for any given date, so you know when to discard that. And so you don't get caught on one of those on a survey. So it's just a huge problem. CMS has said one single dose vial with a 28-day marked on it is a failed survey. We don't want you to do that. We don't want you to fail your survey based on a single vial. It's really pretty sad. And because that one, in my estimation, could have been human error. We missed it, but CMS doesn't agree. So we can't do it. And I did it once. I had them cited as standard level deficiency because I said to the surveyor who called me, hey, let's do it standard. They had like 50 vials in the clinic, so only one had this problem. And everybody in the clinic knew it was an error. It was egregious. I cited it as standard because I wanted them to prove that they went back and retaught it. 3 months later, CMS overturned that survey. So they do that to us, just like we do to you. So we have to abide by that. And so it is egregious. I get that. So we don't have any room for human error on the medication side. So one clinic up in the Great Northwest they did have a problem with vials. It turned out to be a physician who didn't want to waste. And I understand that. But any vial, they did this test for a month. Every vial that came out of the closet, no one could put it back, but the nurse assigned for the day. And so that's how they found their culprit, and they found the people that were making the errors. And so open vials were her responsibility, and she checked them all. So it's something to think about if you think you have a problem. Controlled substances, obviously, we want to know where every dose of that testosterone went by patient name on a log, and that's secured. And again, it has a log. So samples, we have a log as well. Should there be a recall, we know where every lot number went. And this is a nice little chart from stickers from West Virginia. I love this, that they had so many samples they couldn't keep track of. It takes hours to look through this big cabinet of samples. And so they sticker them going in. So let's say today, perfect example, today's December 1st. So let's say that's this maybe black color. So all the hot pink should be out of there. Okay, because that's last month. And so it really works well for them. It's real visual and quick and saves a lot of staff time looking through those expiration dates. They're always getting smaller and smaller. Remember this, in your refrigerator, no medications, and water bottles should be in the door. So never medications. If you purchase a fancy med refrigerator, it's fancy because it has no shelves in the door for a reason. CDC says that body of the temperature is not the same in the door. So we want to take up that dead air space with water bottles. Now, we've had a state surveyor cite one of our clinics wasn't one of ours, it was a state surveyed clinic for food in the refrigerator because of those water bottles. If you are concerned about that, right? Do not drink, not food. We even had the survey, the clinic called me and I said, take the surveyor to the website at CDC where they recommend this. And the person wouldn't believe, she thought it was food. It's not for drinking, it's for taking up dead airspace. Lastly, we see commonly cited dorm style refrigerators. Now, there are under counter refrigerators that are appropriate for medications. The dorm style that you get at Walmart or Target are not acceptable. They're not good temps. They may be good for your snacks, but they're not good for medications. So you would get cited on that. And remember, Everything in the clinic that has a date is subject to the survey. TEL for gloves, peroxide, needles, gauze, all those things. And so we want to make sure we're checking all those. Those were all expired in a clinic I saw a couple years ago, not in Oklahoma, but it was a nearby state. And then this Sharps container is not acceptable in a patient care area because I could basically get that whole thing in my backpack if I was hot to get some needles. And we all know there's those patients, we're not going to help them out. We want to get them different kind of help. Now, gloves are a tough one because they expire, but boy, it's hard for me to believe they're not still sterile because they're not damaged, broken, open, wet, all those things that we look for in event-related sterility. I would mark them not sterile just so you could still use them just to appease a surveyor. But I think that is done to sell more gloves, and that's just my own personal thought on that. Now, instruments. If you're sterilizing instruments in the clinic, you need to do it right, obviously. Excuse me. You need to read the instructions on the unit you're using to sterilize and be sure that you're doing it by the instructions for use. If you're accepting sterilized instruments from the hospital, you need to know what their process is. So we have full confidence that when we hand an instrument to a physician or a provider, you know that you're giving them a sterile instrument so they can perform the procedure without risk of infection. This is a very common question. There are two types of chart reviews. There's physician oversight. If your state is silent, you choose a number and put it in your policy. So you have an experienced NP. Let's take 5 charts a quarter, 5 every 3 months. And he reviews it. There's a log with the 5 patient names and the MD signature at the bottom. Even when your NP has autonomy, that doesn't matter. There's a federal program that requires this, okay? Make sure your log matches your policy. If your state requires a certain number, obviously that makes that easy, and that's what you're going to do. But you must be able to demonstrate to the surveyor that that is happening, okay? It's a hard one, especially in states where the NP has autonomy. We'd love to see that one changed. I don't know that that one's going to change. And then the other type of chart review is your quality improvement. This feeds into your biennial evaluation. So every 2 years, you're doing this nice evaluation of your clinic. And to get there, they would like 70, 80 charts in that biennial. Well, you're not going to wait 2 years to see a problem. So once a quarter, you're going to get a log and you're going to check, let's say 10 charts for quality, for completeness. It's done by someone that you taught what a complete chart looks like. What's that 49110 that makes a complete chart? Some people add on billing and coding information and let somebody that they've trained. It's not a physician. It's not an NP. It's someone you've trained to check for charts. And then what do you do about it? So once a quarter, you review 10 charts and you find out, Mary's not signing off for charts, or there's three of those charts of the 10, there's no notification of the patient on abnormal labs, those kinds of things. That's what we're looking for. And that's what you should be looking for, not wait 2 years to fix a problem that you have. Well, another thing that happens frequently is consents are missing. It happens when we scan consents in. So you have a patient sign and then you're scanning it into the record and somehow they don't all make it. And of course, the surveyor comes and there it is, no consents. Now, your patient care policies are developed with the advice of your group of professionals. There's 3 people on this list, 1 or more physicians and 1 or more PAs or NPs. 1 is good. And then 1 person who's not a member of the clinic. Okay. So for provider base, that's relatively easy. It's typically a nurse, quality nurse from the hospital. That's wonderful. Sometimes it's a CNO, anybody that can look at your policies with some degree of education and sign off that they're good. For independent clinics, you have to find somebody outside of your clinic. The rule is they're not on the payroll of the clinic. So they work at the hospital. That's absolutely fine. Now, you must be 51% primary care. I hit that a little bit before. There's the Appendix G quote. We're seeing a lot of specialists come into rural, and that's a wonderful thing for our patients. But you will be audited based on number of visits for psychiatry or derm or ortho if it's more than 51%. And I know of 2 audits last year, and they both were because of Suboxone. And that's really most unfortunate. And they were told to move that physician out of the clinic or no longer be a rural health clinic. And that's sad because they were performing a great service in that town in Missouri. One of them was, and they had to they lost that case. They had to move that fellow out of there. It was really very sad. So just beware of that. We want that service provided. We need that service, but we can't go over that 51%. So your policies must include a description of the services that you provide directly and those furnished through agreement or arrangement. So that's like your mission statement. So we provide primary care medicine from birth to death, let's say, and we refer colonoscopies, mammograms, surgery, orthopedics, whatever. Just write a sentence and you'll be fine. No worries. Now, your guidelines for medical management is the reference that your NPs and PAs use to look things up when the medical director is not available or another physician's not available. Most of the time we're hearing up to date. Just make sure it gets in your policy. Hippocrates is another one. So it's an easily fixed thing. And then we would ask the NP where she goes to look stuff up and she'd say up to date and we're all good. The maintenance of healthcare records, that's somebody that's responsible for keeping your records up to date and accurate. And that would typically in the provider base, it's IT at the hospital lately, it seems. And then your periodic review of your services is your biennial evaluation. The rules for storage, handling, administration of drugs and biologicals is a rather beefy policy, and that should include all the elements needed for a good medication policy for your clinic. And again, these are reviewed at least every 2 years by this group, the MD, the NP or PA, and that outside person. And that signature page, we would look for that signature page. And it's going to say, and this just happened, unfortunately, 2019, early in 2019, and we're well into 2021, almost, we're in the last month today. And so they were out of compliance. That's not a standard, that's not a condition level failure. But it is a deficiency. So make sure you go back and look at your dates because we miss that a lot. We've seen several like that recently, and we know why. You've been busy with COVID. And so just go back and check and make sure you're good with the 2 years. Now, your emergency services, this changed nicely a couple of years ago so that the physician and the NPs and PAs will decide what emergency drugs they need in their clinic. So if you're located in the hospital and it's 4 doors down is the ED, you don't probably need a really robust box. But if you're 20 miles down the road, you have to give thought to that. And how long is it going to take for 911 to get there? Either way, you need an emergency box. That is required. It's just that what's in it is now your decision, which is really nice. We don't need all those categories of things. So, most people have baby aspirin and EpiPen. Other things are your choice. You do not need to have antibiotics. Remember that list, snake venom and all those things, not required any longer. But to prove that the medical director did review and agree with that list, it's in the policy. And he signed off on the medication, on the emergency services policy. So you're good. And it's portable. We take it and run, and we grab an oxygen tank perhaps and this box, and we go to room 2 and we take care of our patient. Somebody's calling 911. So that's the whole point. Okay. But this is your medical record review. This is ours. I'm happy to share that. It's in the checklist. So this is nothing added here. This is exactly what's in 491.10, and you can make a chart and add billing and coding if you do your reviews. Your patient names would be here. In your case, you can use patient names. When we survey, we cannot take your patient names. We have a code for patient names for our review on your survey. Oops, and I see the word annual there, and that's because I just did it for Louisiana, and that should have been changed to biennial. I am so sorry. It's biennial program evaluation. I'll fix that before I send this out. And so, sorry, someone just came for my husband. There's a review of your program every 2 years, which includes a utilization of clinic services, including at least the number of patients served and the volume of services, a representative sample of active and closed records. So when I talked about the chart review every quarter, 10 charts, every other quarter, throw a closed record in there and mark it so that when you get to your biennial, that surveyor is going to look for, did you review closed records? And there you'll have it. So what is closed? Number 1, obviously a deceased patient. Number 2 is somebody that asked for their records and moved away. And number 3 is your policy. So our policy says a closed record is somebody that hasn't been here in 3 years. That's great. So 1 and 2 years is a little short to call them closed, especially during COVID. We haven't had patients come out. And then in your program eval is your healthcare policies that are reviewed every 2. And why do we do it? To make sure we followed our policies and our services were appropriate and what changes. Make sure you do that evaluation of your review to say, here's what we found, here's what we're doing about it to change it. And it is biennial. Okay, EP. So quick review of this. I did the beginning changes in the start. The hazard assessment must be documented and a plan for each hazard. So if we have 5 hazards, we have 5 responses. We have a communication plan that's complete, including the name and address, not address, excuse me, the name and phone number of each person in your staff. It's got to be in the policy binder. It is not just good enough in your phones, because it's required. It's a federal requirement. Must address volunteers. You don't have to have them, but you have to address it. So you put a statement that says your clinic's chosen not to utilize volunteers. You must address how refrigerated medications are handled in a power outage. And I'll just say this, it's 5 o'clock Friday night. You're just packing up, going home. Hope you got out of there on time. Power goes out that night, doesn't even come back on until Sunday afternoon. How do you know Monday that those drugs are safe? You have to answer that question. There are many ways to figure that out. You do not have to get a generator. There's lots of different ways. So make sure you can answer that question so we know drugs are safe on Monday. And then we're going to have a log that we've trained our staff on our emergency preparedness program. And there's a log and a date, and it's every 2 years. Sorry about that. That's my mistake. So the testing is 1 exercise event or tabletop a year. I changed this side because Louisiana still has 2 a year, but the rest of us only 1. So you've had an event last year. If you wrote it up and did an after action report for COVID, and you have the same event this year, but it looks different, and you wrote it up, you are good. Next year, 2022, we can all do a nice tabletop and hope we're not dealing with the pandemic, right? But the analysis is what we find is missing. So you did it, but you have to write it up. And I can send Lara an example of a COVID after action report if you're interested in seeing that. Now, and again, the new thing is your exercise or tabletop must be one of your hazard assessments, and don't want to miss that. Okay, so you're going to do your mock survey and interview your staff. Can they articulate what they're responsible for? Do they know what it takes to get fired around here? That's really very important. Do they know the answer to that? Do they know the process for evacuating the clinic? That could be for fire, for chemical, for tornado, while we're hunkering down a tornado, whatever. It proves that you've done some preparation. And they answer questions for their job responsibilities. The MA does not need to know the job responsibilities of the nurse practitioner kind of thing. So, specific to their role, and where to go for an answer is really very important. Okay, before I get into this new law, are there any questions, Lara?
I haven't seen any yet, but some of the questions that I had received previously were really around the staffing and just who are the musts, and then nursing requirements.
Okay, was anything specific? Did I hit it on going through that?
I think largely you hit it, but I think the questions we've received are really, do you have to have, and it's really around the providers. And so, but yeah, I think you did hit it. If anyone has any further questions, send me an email or put it in the chat. But those are largely the questions that I've received prior to this webinar were staffing requirements.
Okay, so you must have a W-4 NP or PA. That is a must. So we look for that W-4. That means they're an employee. All the rest of them can be contracted. One must be an employee. That we hope will change, and it's in the rule to change when it gets passed. So that's number 1. You must have a medical director. By the way, there's no waiver for a medical director. You can get a waiver for your NP or PA. Medical director, you just keep looking for one and you notify the state that you've lost your medical director, and hopefully you find one rather quickly. And then nursing response, you don't ever have to have a nurse. We have clinics with a NP and a MA kind of folks. That's up to you. There's no requirements for an RN. You just have to have people trained to do the jobs that you need done in your clinic. Okay. All right. So this is the law that is causing great fuss today, as the courts have said this is not legal. We have been instructed by CMS to start surveying to this Monday. So you can imagine that the compliance team, and I'm sure every state agency, they're all wondering, and what do we do on Monday now? And I don't know yet. So I'm going to suggest that the law is there, 491.8D, on staffing and staff responsibilities, and that you should start. If you haven't already, I would get prepared. We are going to look at this Monday. We are not going to cite because of the stay that the federal courts said that this is not legal. Okay. I wish everybody'd be vaccinated, but that's not real, apparently. I'm vaccinated and still got COVID, which is why I'm coughing. So at any rate, you must develop policies and procedures to ensure that all your staff are fully vaccinated. You cannot start a new employee unless they've had at least one shot of the two-shot one, okay? And fully vaccinated is 2 weeks after. That would be not in effect till January, actually. So everybody in the clinic, the employees, licensed practitioners, students, trainees, volunteers, surveyors is included, actually, but it's not listed in the law. And individuals who provide care within the clinic are required to be vaccinated. The policies and procedures do not apply to someone that's doing full-time telehealth and never sets foot in your clinic. All right. So if they have no contact in your building, your billers in your clinic do have to have the vaccine. So just remember that this is for staff that are not physically in the clinic. Then you have to have a process for ensuring all staff specified in this section who have pending requests or have been granted exceptions are logged in a separate way. So, so I'll use myself. I just got over COVID and I had the monoclonal antibodies. So I have to wait 90 days to get a booster. So that would be the kind of thing I'm thinking of some other reason. Maybe you're pregnant, maybe you're breastfeeding. So there's reasons to wait. And so you're going to document all that in some kind of log, okay? And then exceptions. You're going to have a medical exemption policy and a religious exemption policy. If you go on the NARC website, there are wonderful examples of those that you can download and use in your clinics if you haven't gotten that far. But I would suggest that you should be prepared for this. I'd be lying to you if I told you which way I knew this was going to go. We've obviously never seen anything like this, none of us. And so pandemics for starters, right? And so make sure that you have at least started this so you don't get into a pickle if you have a survey next week. So, and then number 3 is you have to have a process for ensuring that you follow recognized infection prevention and control guidelines to mitigate the transmission of COVID. We already are looking for that. We know you have it. We see your signs. Go back to the car, call us if you have these symptoms. We see your social distancing. We see your masked up in the clinic and your hand sanitizers. And early on, we saw one room segregated just for patients with those symptoms, all kinds of things. You see patients outside in the tents, in the drive-throughs. All of that is your process here. So we're going to ensure that you are following them. And then 4 is a process for tracking and obviously securely documenting its health information, the vaccination status for all staff. Process for tracking the staff of anybody that's received a booster. Now, the law does not say you have to receive a booster. It's telling you that you need to have a list of people that have received the booster. That's all it says. So that's what we're going to go with. A process by which staff may request an exemption. Obviously, that's real specific. Medical exemptions are clearly specific. Some of them are even on the package insert for the vaccines. Religious exemption is another thing that it concerns a lot of people because there's civil rights issues involved, and you will decide that. Pretty much, we're going to see your process for religious exemption, should this go through. And we're going to see a paper signed by a pastor of some sort, a questionnaire on what religious belief you have. You fill that out as the employee that exempts you from this. How long have you had this this thought kind of thing, and then signed by a pastor of some sort, and we'll accept that. I promise you that we will accept that. So it's one way around, not around, I mean, but one way to deal with this. All right. And on the medical, it's recognized clinical contraindications. And again, those are signed by a licensed practitioner. Obviously not the person asking for the exemption. That'd have to be a different provider, but it is by an MD or DO, okay? And then all information specifying which vaccines are they're contraindicated for. I found that an interesting statement. And so I will give you that for what it's worth. And a statement by the authenticating practitioner recommending that staff be exempted from the vaccination requirements based on recognized clinical contraindications, little duplication of efforts there. And then number 10, contingency plans for staff who are not fully vaccinated. You're going to have a plan that says, okay, I'm not getting vaccinated. What are you going to do with me? And that's going to be your process. And we do not know yet what the ramifications are if we survey your clinic and there's 15 people that work there and one of them is not vaccinated. We'll have to cite it. We're not going to cite it next week, not based on these changes. We're going to teach and we're going to say, okay, what's your policy for that person? It's a very, very, it's difficult situation to say the least, Okay, that's the end. What kind of questions do we have?
I don't have any in the chat, but we have 13 individuals on the call. So this is your time to ask any questions y'all have.
Hi, Kate. This is Sheila Chrisman, Compliance Officer at DRH Health in Duncan, Oklahoma. This was very, very helpful, but I have a question.
Sure.
On the religious exemption, the RHC compliance for that would be that the pastor signature is required?
Yes, he's going to document why you need this religious exemption.
Okay, and the pastor signature is required.
Now, let me just say this. On the NARC website, I just actually looked at that this morning for somebody. It was a form only completed by the employee, and it was all about your religious beliefs and why you think you need this exemption. So I will tell you that I would probably honor that as well.
Okay, that's what I wanted, because I was going, wait a minute.
That's a good question, because it just dawned on me that there was nowhere on there for a pastor. That was last week's discussion on the pastor. I would want as much documentation as I could get to help myself out on the survey. Okay.
And as far as right now, I know that at a certain point, when the mandate came out, we stopped hiring folks who were not vaccinated.
Right.
Now we've got this stay. You're stating that you would continue to do that moving forward until we know for sure what's going to happen.
I'd be hard pressed to advise you on that, but we've reached out.
We're having a lot of open dialogue. We're having a lot of communication, like our CEOs having town halls, and and we are giving expectations if the mandate goes through. These are your expectations if the mandate continues on. If it comes back and it continues, we expect this. So, I'm just kind of trying to work through all of this in my head.
Yeah, so are we. Believe me, we reached out to our attorney this morning already to see what his read on it, but what we need is CMS's read on it. Right. They have not commented on any of these lawsuits yet. We have a call next Tuesday at 12:30, all the accreditors, Joint Commission, us, all DNB, all of us. And so we'll be quite anxious for that one. And I will get word out if I know anything different on that one.
That would be great.
I think you're wise. So if you'd hired me today and I'm not vaccinated, what are you going to do if it does go through? What are you going to do with me? You've put money into training and all the rest of it, orientation. And so I would go on the assumption for a bit here that it's going to go through.
Right. Okay.
Again, I don't know. When you see all these states lined up now, I don't know.
Right. And that's one of those items too, that if you're going to do it for RHC, you need to do it for everyone, because if you hire someone in the hospital, then they transfer to the RHC later. And I just want to make sure that we're consistent across the organization.
Oh, the hospital is the same boat.
Right.
Yeah.
Right.
Yeah.
Okay. And then I had things written down here. So 60 days, January 14th, you're thinking it may go ahead and get extended. When you say how are they managing the waiver? Let me go back. I'm sorry. They're managing the waiver for the 50% for the nurse practitioner, and where are they at? What they're doing now is they're notifying me. And as the compliance officer for the corporation, I'm keeping a humongous spreadsheet, and I'm keeping track of what's going on, because I want it all in one. Is that okay?
Absolutely correct.
Okay.
And something else you just said, I think I misspoke. 3 months from January is April, not May.
April. Yeah. I've got all that written down. I think that's it for what I was. Oh, and the emerging infection disease as part of our HBA. I think that's a good idea for the entire organization. I just want to key points I want to check on. I like the Cornell University. Thank you very much. I think that's all I had.
Thank you so much. Nice to chat with you.
Thanks, Kate.
Mm-hmm.
Kate, I did receive a question via email. Does the clinic have to have the providers, or does the clinic sign have to have the provider's name on it?
It does not.
Does not. Okay.
Not. The only real signage requirement is, there are two. One is that it matches your 855A, so your legal name or your DBA. And number two, if you have Lara's clinic on the sign, we need to know somewhere in that lobby who owns that clinic. It could be the hospital, it could be an individual, but it's required that you disclose to your patients who the ownership of the clinic is. If you've got it in your name, a subsidiary of St. Joe's Hospital, that's fine. You don't need to do that. But if it's a name that's not identifiable as the owner, then you need to post that.
Okay. All right. Do we have any other questions? Sheila asked if we'll be able to get a copy of the slides.
Absolutely. And I'll correct the biennial. Thanks for that. I will get those out to you. Poor Louisiana, they do everything different.
All right. Are there any other questions or things that you've ran into in your clinic? All right. Well, thank you all for your time, and thank you, Kate, for your time. This worked out great because we had lots of updates since Thanksgiving. So,
right. And also, folks, that email address is good, and I will be happy to answer questions. Never an issue with that. Please, questions are free. Okay.
All right. Well, thank you guys for your time. If you guys run into questions, please let me know. I'm happy to contact Kate as well. And y'all have a great day. And again, we recorded this and we'll get it posted on our YouTube channel shortly. So thank you guys.